someone? Have you ever cared? Do you miss someone? Have you ever?
Hello again, I'm Dr. Hung Vu and our show is America's Healthcare Crisis. Welcome to our second segment on the topic of new trends and developments in healthcare delivery. And I'd like to welcome back our speakers, Dana, Dr. Granado, Dr. Henke. Let's go back to where we left off. I'd like to ask Dr. Henke a question in regard to the care in the emergency room. It was my observation, has been our observation all along, especially in an urban setting like San Jose, that many of the problems or issues that I encounter in the emergency room are not strictly medical. You're talking about psychosocial, gang violence, for example, drug abuse, and especially in a place in San Jose like there's so much of a cultural diversity. How do you fit that in terms of improving the efficiency in emergency medicine? In other words, you're not trained to deal with all those psychosocial and economic problems in medical school, were you?
The kind of people that go into emergency medicine are the kind of people who, by their nature, are willing to get some of their training in the College of Hard Knocks.
Okay.
It has to be that way. I think that when you take a look at all the other problems that have their origin in something that isn't strictly medical, you really have to look at the healthy cities concept, the healthy communities concept, which started back in the 50s and now is part of the backbone of modern managed care concepts. Disease does not exist in isolation. Teenage pregnancy doesn't exist in isolation. There's always a cultural or sociological context which helps to give rise to this.
Right.
Obviously, you expect more drug abuse and crime in a poverty-ridden area than you do in an area that's wealthy. I think in emergency medicine, you learn to deal with all of these things. You're not really well equipped to go out in the community and help cure some of these ills, however. And that's one reason that I've gotten involved with the San Jose Medical Center Charitable Foundation, which is involved in a number of community-based projects, such as the school-based health centers, which helps to go out into the communities and attack some of the root causes of some of the social diseases which end up engendering disease.
Yeah, I'm going to say that because otherwise you just take care of the results of our problem, isn't it? Like, for example, a person who's
it's
shot
the pound
by...
of cure instead of the ounce of prevention.
Right, exactly. And you have to broaden your knowledge so much into social issues and even political or economic issues. Otherwise, you just take care of the end results. For example, gang violence. You take the bullet out, you treat the shock, in a strictly medical sense. Next week comes exactly the same thing.
Yeah, we joke that trauma is a recurring disease. It's amazing how often we see a trauma patient, and we've seen them before. There are risk factors for becoming a trauma patient, such as hanging around with people who like to travel heavily armed, drinking too much and driving your car fast without a seat belt. Things like that. If you do those often enough, you're going to end up coming to see us.
Right.
But we do try to get involved in the prevention. Our nurses have been in the community, going to high schools, trying to teach the kids why they shouldn't drive drunk and should use basic common sense.
Right. Instead of just being at the receiving end of it. Let's talk a little bit about medical ethics here. In my opinion, I've been practicing for 25 years now. Underlying each and every problem, there's always at the bottom line an ethical issue. No matter what problem issue you encounter. Let me ask Dr. Ronaldo, because he's a urologist. What is your opinion on phallic implant? There's a saying that people who want phallic implant need treatment between their ears, not between their legs. What do you think?
Well, I think it's a perfectly reasonable therapy for people who want to have it. That's not the only way to treat male impotence. And 90% of the men who have impotence have it on the basis of diabetes. So it's really not a psychological problem for the vast majority of men. So I think it's a reasonable treatment. It works well, and there are many men who do not accept that treatment, who are willing to accept the fact that they're no longer able to function sexually, at least in terms of intercourse. So not every man is looking to that solution, but I think it's a reasonable solution for men who find that a part of their life for themselves and their partner.
Yeah, I guess I mean that was one of the ridicule of the situation by the media, but I don't know, maybe there's like you say, there are real indications for that. But I guess I'm hoping that in the light of managed care and so forth and so on, we need to screen out the people who do that for psychological reasons.
Well, you know, I mean, sexuality is such a basic part of human nature. I think it's unreasonable to assume that someone who has a sexual dysfunction isn't at least as ill or disabled as someone who has heart disease or diabetes. It's a very basic part of human nature, and to ignore it is neither reasonable nor practical.
Okay.
There's another interesting ethical issue, however, which involves urology. I'd kind of be interested in hearing your comment on it, and it has to do with managed care. I was at a managed care conference in San Francisco, and I heard a Kaiser ethicist speaking about whether or not the male population in a certain age group should be screened with PSA, prostate-specific antigen, to screen out people who may have prostate cancer. And this gentleman was arguing that the treatment is so often disabling in and of itself, that prostate cancer is very seldom aggressive.
Right.
His argument was that if you're going to screen out all the people with little bitty prostate cancers, which will grow slowly and maybe not kill them before something else does, such as heart disease or just other natural illnesses, that you're doing the population in general a disfavor. But I'm not sure how many men who wouldn't want to know if they had it.
Well, the problem is that we really don't know the natural history of prostatic cancer, and there are distinct populations. There's the population you referred to, in whom the cancer grows very, very slowly, and they will probably live out their normal life expectancy. But there's another population where the cancer is very aggressive, and those people can be saved with appropriate therapy, you know, in a timely manner. Unfortunately, as yet, we're not able to distinguish those two populations, and as a result, there probably are many men who are hurt more by the treatment than they're helped, and becoming impotent and incontinent as a result of radical prostatectomies. And of course, there's an economic incentive involved too on the part of the physicians.
Yeah. We talked earlier about competitive managed care. And I see here two ethical issues. The first thing is that, unfortunately, a lot of areas that make money and feed so many people, say angioplasties, amazingly a wasteland. I mean, I could not believe it when I watched Dateline. Dateline was one of the national TV segments, which claimed that up to 300,000 annually angioplasties are not indicated or necessary. That's frightening, because you're talking about billions of dollars that really feed on an army of people there. And how do these then get them from doing something like that for a living? And it's totally wasteful. On the other hand, the incentive is that is the area where the money flows in. You have,
I think you're going to get into the ethical issue. It's not only the money, but it's the risk factor to the patient. That's an invasive procedure that if there are that many of them that don't need to be done, how, again, like your example with treatment for prostatic cancer, who's really being helped and who's being hurt? And I think when you talk about the ethics issue, it isn't just the financial incentives or disincentives, it's also the physical risk to the patient. And that is of concern when you look at the medical industrial complex that you're referring to, and what is the end result on the consumer or the patient.
I don't see how we can go around issues like that except by just education. And people have to be aware. And I think that's one of the beauty of our system, is that we have a very dynamic and open system. At least, people are not gagging me for what I'm saying here on TV tonight. I mean, like in the Inquisition or whatever. Because at least I think that's the beauty of our system, is that we are given the opportunity to contribute our share, whatever it is. And I mean, you want to say something though? Thank you.
Yeah, I think that education is good, but it only goes so far. For instance, it's hard for most consumers to be able to tell when they need angioplasty. The consumer may know, I've had chest pain. They say it's my heart. The consumer doesn't know, do I have a 40% lesion or a 90% lesion? Well, we know if you got a 90% lesion, you need angioplasty. If you have a 40% lesion, you don't need angioplasty. But there probably are people out there with 40% lesions who are getting dilated.
Yeah.
It's just that they don't know who they are, and it's going to be very hard to give them enough education to really enable them to make that decision. I think you need more outcome studies. It would be very interesting, for instance, to take a look at angioplasties in the Kaiser population, where they're all capitated and there's a financial disincentive to do extra angioplasties, versus a fee-for-service setting where you make some extra money with each additional patient that you dilate with a balloon.
Yeah, again, I have to say this because for me, I come to this country, I'm an immigrant, and I have never really looked at the opportunity to become American purely for economic aspect of it. There are other opportunities. I mean, unfortunately, we are a capitalistic country, so we look at the U.S. as the capitalistic model where you come here to make money. But in medicine, for example, there's so many other things that we can be motivated to do ethically. And I think one of the things I learned in one of the shows we produce is that eventually they say that it's not so much an ethical correctness, but an economic has to. In other words, ethics and economics converge, and that is only when people would wake up and realize that, for example, you would go bankrupt if you keep on doing things that are not as necessary. I think it's very unfortunate because, in my opinion, I hate to be accused as preaching, but if we consider ethical standards and consideration as a first thought, then none of those things would be so, we're not so stuck with all those issues. In other words, I think that, if, for example, it disturbs me that most of the problems that I can see in our medical system are preventable. 30% of the problems in our society are due to tobacco, another maybe 12% alcohol, and maybe 35% due to food. And those are the things, he's talking about 60 or 65% of the problems you can do something about. But you have a whole industry of producing tobacco and alcohol, and it fits. It's a crazy system because so many people get upset if they lose their job, and yet it feeds on a very unhealthy kind of situation. It perpetuates itself,
Well, it's the free choice that is. Been part of the fabric of America, that good or bad, we have the choice to smoke or to drink or to eat the wrong foods. The education process that's telling generations that these are bad choices takes a long time.
Except that I don't want to pay for your bad choice, though. If you go to the hospital because you've been smoking all your life, don't expect me to pay for it.
Well, this is where we're coming to, and I think when we look at some of the rationed care principles that have been proposed, these are going to be some of the difficult choices we're going to have to make as a society. Whether it's transplants or whether it's the issue of long-term obstructive pulmonary disease or any of those things, there will become a tolerance, and I think you're probably right that it's going to be economically driven rather than ethically driven.
Yeah.
Well, they can be a crossover. I have a friend who's in benefits for a major communications company, and he's trying to help design a program which would shift more of the cost of medical care onto employees who made unhealthy lifestyle choices, such as choosing to smoke, versus those who did not.
Well, the question would be whether people with healthful lifestyles be given some reward in terms of insurance rebate, and people who have unhealthy lifestyles, should they be penalized by paying more premiums?
Well, that's already being done.
You think so?
There are smokers' rates for health insurance and non-smokers' rates.
Oh, and the car insurance, life insurance.
We passed the motorcycle helmet law on that basis because it was costing society lots of money to provide care for these people.
And the seatbelt law.
And the seatbelt law.
And the bicycle helmet law.
Yeah. It's amazing. It reminds me of the British saying that you can count on Americans on knowing what to do. Eventually, after they have tried everything else. It's really sobering, because eventually you have to come down to something like that.
I wouldn't like your viewers to go away with the thought that all the excesses, either too much care or too little care, are on the basis of economic incentive. There's no doubt about it. There are wide discrepancies in different parts of the country in terms of how they approach different health care issues. But many times that's because no one really knows the correct way to treat the particular condition. And the people who do too much really believe that what they're doing is appropriate, and the people who do less believe the same thing, but no one really knows. And that's what Dr. Henke's been talking about, outcome studies, to determine what really is the appropriate way, the most cost-effective and efficient way to treat
See, that is the other
condition.
element that has to be injected into different studies, because traditionally speaking, all the publications, research papers especially, come out of the universities who had no incentive whatsoever in terms of economic issues, isn't it? I mean, they study things and they just go through the 20-yard doing different things and have no concern about economic factors whatsoever. And now it comes into play, because I mean, are you aware of any studies in the New England Journal of Medicine, for example, when you're talking about any of the issues we're talking about now? I don't think for a long time.
Well, I know that the VHA, Voluntary Hospitals of America, has done a lot of such studies. The Intermountain Group up in Utah has done a number of such studies. When money starts getting put into it, people will do the studies.
But that's a recent development. I mean,
Yes,
traditionally
it is.
for a long time.
It isn't a long tradition.
It's a very recent development in terms of, and it's becoming truly, as our world gets smaller, as we become more and more electronically dependent and electronically interlinked, we're sharing information much more quickly and much more rapidly and in a larger area than we ever did before. So the concept of being able to study large populations across the country is becoming a reality, and we can do it in real time rather than retrospectively, which has been part of the problem. Is we've collected the data, it's taken a long time to analyze it, and by the time we come to a conclusion, there has been a shift or a change. So
some of these groups are continually reinventing healthcare to try to achieve the same quality standard, or hopefully higher, and reduce the cost of care, and they keep reshuffling their algorithms and parameters and keep driving the cost down. This group in Utah has been doing it 7, 8, 9 years now.
It's the continuous improvement cycle, which says you can always do it better. And that we don't stay stuck in one particular approach because that worked in 1992. This is now 1995. We have new technology, we have new knowledge, we have new ability, and so we have to look at how we do that. And that's a real change, I think, for medicine to be that active.
The problem with technological advances is that it created a attitude of believing in quick fixes. In other words, people, think that we can go to the moon. So, I mean, if I smoke for 30 years, if I can afford it, or somebody else pays for me, I can go in and get angioplasty, and I can go and smoke again. I think technology has to be used judiciously, don't you think? Because it's a double-edged sword, because it can give the wrong kind of signals to people that they can wreck their body, and they go in and have a liver transplant. You might, you were suggesting something in that direction earlier when we talked privately.
Yeah, I think one of the biggest ethical issues facing medicine today is the entire issue of transplants. Is it appropriate for someone, as you say, to abuse themselves for 30 years with alcohol and then have a liver transplant? I have some serious concerns about that.
Who might not have been a very good candidate.
To begin with, is it appropriate to, spend $100,000 to save a severely premature infant when we're facing worldwide overpopulation. No doubt for that particular set of parents, it's a worthwhile issue.
Or when the choice might have been $2,000 worth of good prenatal care, as opposed to...
Or the issue of the young lady who was severely retarded and had congenital heart disease, and they didn't think she should be operated on because she was severely retarded, and some advocates went to court to try to get her heart surgery. And then you wonder, if you took that money and spent it in Bangladesh, or, well, even in America in poorer sections, would it really have a better net impact on the health of the population?
Well, and what we've sort of come back to is, again, that concept of prevention. If we have a healthier population to start out with, we have fewer problems downstream. And I think one of the challenges in the next 10 or 15 years is going to be the aging of the population and the increase of illness and issues that go along with aging, and we're going to have more of the population in that particular age category than we've ever had before.
Right, right.
And we know that they also consume a tremendous amount of the resource.
Right. It is a well-known fact that up to something like 50 or 60% of the health dollar is being spent during the last 6 months of life.
The trick is knowing when that 6 months is.
Every time. Right. And I mean, that's where the Oregon health plan experience comes into play, because I mean, you just cannot give people the entitlement of being hooked on a respirator forever. Even if you're brain dead, like a baby who's born without a brain, anencephalic, they write them off the list from the beginning. I think that makes sense, because imagine, I mean,
There's one in Southern California where the family has gone to court and have forced them to repeatedly resuscitate the anencephalic baby, and if the emergency physicians try not to do it, they come in with all the lawyers and they basically force them under threat of severe legal duress to keep resuscitating this baby that has no brain at all. And that money, that's a lot of money.
It's really interesting to know that we is a bastion of individual rights. But we have come to a juncture whereby you have to sacrifice some of the individual rights for collective goods. Otherwise, we don't have any rights at all. Because that's to me, that is to me the reflection of a disease of excess. For a very long time, after World War II, for like 20 years, we became very, very powerful, very very rich, and we still have a lot of resources. But again, we will be running out of them. And
I don't think we're very judicious necessarily where we spend our resources either. I mean, if you take a look at Medicare, which is such a politically charged issue that nobody will touch it. I mean, I will. I think there should be some degree of means testing. My folks, for instance, are better equipped to pay for their medical care than lots of poor elderly people. Why should they receive the same benefit from the government, as somebody, who really has no resources to pay for their care?
You should be a regular on our show. Come here again. I love it.
Never know, I may get assassinated.
That's great. No. I think that, again, I think that's the beauty of our society, is that I learned to speak English as a third language, So it's not easy for me to do something like this. But again, I think that the challenge and the opportunity is there. I think that we as physicians have to take an active part in, first of all, erasing all the misunderstanding, and then take active part in the political process. What do you think? Are we doing that?
Well, I think part of the reason we're in the position we're in now is because physicians have not done that. They have not spoken out about these social issues surrounding medicine. They've always taken the position, I can't make that decision, I'm taking care of the patient. And that may be true for the individual patient, but I think physicians do need to be more outspoken about what should be done. What should be done in terms of transplantation? What should be done in terms of prematurity? Physicians have been very reluctant to do that. And I think that's part of the reason we're in the position we are today.
I'm hoping that more and more physicians will utilize the available resources in mass communication to put right on the table some of these sticky issues, because otherwise we had a lot of power and opportunities for a very long time. We're talking about from probably the 65 to 85 for 20 years. We did whatever we wanted. And then now, we complain that the insurance take it away from us. I mean, we had the opportunity, but for one reason or another, we didn't have the vision that this is going to come to something like this. I mean, we just, and I have to say that from my own perspective, I was trained in pediatrics. I believe there's a big dichotomy between what is being taught in medical centers, which is very pathology-oriented, and what we use in terms of knowledge in the community. Mm-hmm. And I mean, I was trained into diagnosing and treating the disease I never saw in private practice, and it's a total waste of time and resources. And unfortunately, the professors in the universities look at a Nobel Prize, and they want to discover something very rare and make them famous, but we don't see them outside in the real world.
One thing I'd like to say, though, is that I think that the younger physicians that I'm seeing now are getting a much more humanistic, broad-based training than I received, many years ago now. We were taught to be narrow technocrats, and the younger physicians are taught to be humanistically oriented and to see the patient as a whole person. Now they don't mind getting people in medical school who majored in liberal arts. Yeah. You were supposed to be, narrow science-oriented when I went to medical school.
It comes back to the Renaissance day, when the physician was many things. He was an artist, he was a scientist, he was a poet. I think we're running out. Actually, I have a little present for you. I wrote this little poem because I think there's so many unhappy doctors, one reason or another. So I wrote a piece called The Happy Physician. I'd like to dedicate it for all of you and the viewers here. The happy physician does not focus on making money. He would rather concentrate on how good his doctoring could be. He works diligently for a modest income to provide for his family a warm and cozy home. He is satisfied with a supportive wife, well-behaved children, a modest home to run. The happy physician finds meaning in the work he does every day in a quiet way. He finds enjoyment in quality time with his patients, would rather teach than treat, would rather be than do. He is capable but not pretentious, nor overconfident of his competence. Forever conscious of his limitations, he tries to expand knowledge through continuous education. The happy physician understands the whys and the hows of the current crisis from within and without. He is not drawn to power and vanity and would rather choose patience and honesty. In the midst of chaos, he knows he will survive the waves of discontent, no matter how rough the ride. The happy physician is the most crucial element of a system of care moving in the right direction. Ladies and gentlemen, we just had the opportunity to interview 3 great speakers, and I really appreciate their presence here tonight. Our show is America's Healthcare Crisis. So long. Thank you for watching. Good night.
Someone, have you ever cared? Do you miss someone? Have you ever shared? Do you need someone to always be there when you feel lonesome and deep in despair? Do you need someone to dry up your tears? Do you need someone to always be near? Do you have someone to stay through the years?